All right. Another Thursday in. Let's get this thing rolling. We have, how many studies do we have today? Four. So we've got 7 studies. These are, most of them are self-explanatory. So while there's 7 on the docket, I don't think it's going to take us that long to actually get through them. First one, the effects of eccentric focused exercises on the shoulder. This one is, frankly, I don't think they needed to go through everything that they did with this one. They took 32 male amateur baseball athletes, assigned them to either the eccentric focused or general treatment groups. The general treatment group received a 4-week intervention with hot pack application and stretches, while the eccentric group received 3 additional eccentric exercises. So really you're comparing more or less hot packs and stretching to hot packs, stretching, and then actual exercise. And it's not surprising that if we're measuring range of motion, strength ratios, endurance, pain, function, etc., that the eccentric group is going to win out. I don't think this is what they claim in the inclusion, that you have to do eccentric focused exercise. Like, I'm not saying that's bad. I love eccentric exercise. Like, it's great for the right time at the right place for the right person. If I don't feel like doing a whole lot of reps, doing some slow controlled eccentrics, you'll feel it for days. Like, there's a lot of benefits to it, but I don't think this conclusion is necessarily correct. Why? Our research found that eccentric focused exercise program positively enhanced shoulder horizontal adduction range of motion and endurance. This validates that incorporating eccentric strength control at newly gained angles can improve posterior shoulder tightness more effectively. Okay, well, yeah, pretty much any exercise will. You're doing more for the shoulder in ways that the shoulder likes. Of course, it's going to do better. I think it's one of those things where if we take the eccentric focus part out, it's a fine study. It's showing us what we essentially already know, that adding in components that uses more of the tissue's capacity than not yields better results. Put another way, rather than just taking the tissue and stretching it and making it warm, having it actually work and function is going to tell the brain, going to tell the tissues, it's going to tell everything involved with that movement that, hey, we need to do this movement, we need to control it, so let's hop to and adapt to allow us to do that. There's nothing in this study setup that would show eccentrics are better than concentrics or isometrics for the same outcomes for what they were asking. So adding exercise to shoulder tightness, positive. Does it have to be eccentric? Negative. Moving on. This one might be the one I spent maybe not a fair bit of time, but I got to really make sure that we cover this one. Shear wave elastography supports muscle stiffness should not be considered a criterion for determining the presence of myofascial trigger points. And then they just stated where they did the study. So trigger points are kind of this, especially if you get on Instagram or social media or get into a lot of the places where you have fights, where you see camps like, it's always trigger points all the time versus there's no such thing as a trigger point, et cetera, et cetera. That's a nuanced debate for another time. Suffice it to say, if we look at this design, or if we look at this study, the criterion that we have to discuss essentially is we accept the proposal that there are, for this argument, such things, or things such as trigger points. The question then becomes their identification, their characteristics, and what actually separates a trigger point from anything else that happens in the area. So that is essentially the discussion that we're going to be having in this study. So a lot of the times people will think of trigger points as a hard knot or ball in the shoulder or in the neck or anywhere else that they're feeling tight, achy pain. And while this has been a classic layman's criteria, and even one that I recall being discussed in schools, my school too, like, hey, if you feel this, it's a trigger point. What we're seeing now is that that may not be something that you can rely on to actually call it if there is a trigger point in the area or not, okay? So remember, as we go forward, this isn't a discussion on are trigger points real. This is more a matter of let's just accept that there is something going on that is real. Now we have to come up with the criteria of what actually makes it a quote unquote trigger point. So what they did is measuring pain pressure thresholds, comparing that to shear wave elastography. So essentially, to do this right, you'd have an algometer, which is just a device that as you press on a certain area of the body, it'll give you how much pounds per square inch are going into the area. And then once the person states, yes, I feel it going from discomfort to pain, they essentially record the amounts of PSI going through that area, and that's how you get the number. So in essence, a lower score, a lower PSI, indicates that it has a lower pain threshold. So it takes less force to elicit a pain response where it's being pressed. So they put a number to it. They then compare that to elastography. So they put, for lack of a better word, it's kind of like a variation on ultrasound, just how much tightness or stiffness is in a bundle of muscle tissue, and they put a number to that too, okay? So that's what we're really comparing. So for results, 40 participants were analyzed. Pain pressure thresholds were significantly lower in latent myofascial trigger points compared to control points in males and females, and lower in females compared with males. So first up, whether or not we're going to argue trigger points are real or not, there were areas that were classically described as myofascial trigger points that had a lower pressure threshold, so they could elicit a pain response much, much sooner. So that is recordable, that is real. But now we compare it to this confounder, I should say. No significant shear wave elastography differences were found between the trigger points and control points, nor between males and females. In contrast, actually, with the accepted myofascial trigger point definition, those areas with higher pain thresholds, so you had to push more force into the algometer to elicit a pain response, exhibited greater stiffness via the elastography. So essentially, in areas that had a stiffer bundle of muscle tissue on elastography, typically had a higher pain threshold. Ergo, they would not elicit a pain response. This is kind of backwards to what is the accepted definition of, oh, it's a thick bundle of muscle tissue that is hyperactive to develop pain. Well, it's like, well, there are areas that are lower on the pain threshold that are more likely to give us pain, but it seems to be the opposite of what is classically being taught. It's not the areas that are particularly stiff. So in conclusion, although pain pressure threshold scores indicated significant differences in hyperirritability between latent trigger points and control points, the elastography measurements revealed no differences in muscle stiffness. In fact, muscle stiffness was significantly associated with greater pain threshold scores, challenging the hypothesis that stiffer areas can be identified as trigger points or sources of pain. So, in conclusion, there are areas on the body and there are conditions that can make areas more hyperirritable. But contrary to what is being taught, contrary to what is out there, it doesn't seem to be one of the criteria that we can go by is either practitioner-based, palpable, oh yeah, this area feels stiffer, or a patient saying, yeah, this is a stiffer area, therefore I know I'm going to have a trigger point there. That doesn't seem to be what we can rely on. So we have to go on other things. We have to go on patient symptoms based on what feels irritable. If we have an algometer, which honestly I've considered getting, we can use that to actually map out these painful threshold areas. We essentially have to use other diagnostic criteria means to say for sure if there's a trigger point there, which honestly, there's only a few instances where it becomes particularly relevant. I mean, if the person in front of me just isn't a healthy individual overall, I could chase trigger points all day, but my job is more going to be taking care of what's going to get them better. So if I get them healthier, if I get them more active, they are less likely to have these broad spectrum hyperirritable areas, because research shows that taking care of your health, getting exercise improves emotional, mental, physical characteristics, and all of those things play into the development and severity of trigger points and vice versa. So if I'm dealing with a generally healthy person, I'm not too worried about it, other than I'll use it as a means to help somebody feel better in the short term, as long as it gets them to their long-term goals. On the flip side, if it's a generally healthy person, then we can actually maybe put a little bit into it if we're going to decide like, all right, maybe they want some specific intervention that isn't going to hurt them at all, like dry needling. It may help with disability for their neck and they feel like they've got trigger points in the neck. Like, okay, as long as I'm not relying solely on the stiffness of the muscle, I'm using different parameters like superficial sensitivity, hyperirritability using tools like 2-point differentiation, Württemberg wheels, other nerve tests like pressure tests versus light touch tests versus prick tests. That would be something now that I have to adapt to my own diagnostic criteria for deciding what treatment gets rendered for what patient. It's no longer the easy feel stiff, poke it with something, feel stiff, smack it with something. It's like, no, we can't rely on that anymore. Now we got to utilize different tools if this is something that we want to pursue as a means of diagnosis and treatment. But again, for me, it's not all that important to really diagnose trigger points as long as we're getting a bigger picture and more a deeper picture, I should say, a bigger, better, deeper picture for the patient other than you hurt because of trigger points. Like, oh no, that's you hurt for so many different reasons besides just trigger points. Again, there's emotional, social, physical, chemical. There's so many things that go into why you hurt that frankly are going to be better addressed to lead to longer lasting results. Than just chasing the trigger points. It's fine to go after them, again, for the short term, because they suck. I've had areas of hyperirritability. You want somebody to treat them. I'm not saying we won't. I'm saying they shouldn't be the focus. Like I said, this study I could ramble on for several hours, but for the sake of time, let's move on. Relationships between trunk endurance, low backs, pain severity, and functional disability in United States veteran population. What do? They went to this Affairs Palo Alto healthcare system. They looked at the records and they really saw in this wide age demographic, so 85 patients with a mean age of 53 years, what did they see? Well, trunk endurance in these 85 patients seemed to be correlated with low back pain severity. So where was it? Here, trunk endurance was significantly associated with low back pain severity and Oswestry Disability Index scores, suggesting that participants with greater trunk endurance, aka longer prone bridge plank test time, had lower low back pain severity and lower functional disability than those with poorer trunk endurance. And again, this is just a corollary, a marker that we use to benchmark general fitness in an area when testing. It's not that it is causative, like low endurance leads to more pain. It's a corollary, low endurance. Low endurance typically also means lower general health status. So like somebody who typically isn't moving as much, isn't doing as much, like it's not something that we want to just say automatically, yeah, if you have more low back pain endurance, you're guaranteed to never get low back pain. It's like, well, no, you're just stacking the deck in your favor because to get a better low back endurance, you're typically doing other health conscientious endeavors to get you there. It's a corollary, not a causative thing. So not knocking it. It's a great thing, like kind of like I do with grip testing. It's the same thing with grip testing. It's not that you're automatically super healthy if you have a great grip. It's not automatically you're terribly, you're doomed for the grave in the next week if you have a poor grip. It's a corollary. If you have a weak grip and we can't explain why, you're at a higher risk for a lot of things we don't want. Just like if you have a strong grip, it's like, okay, as long as I know this person is generally otherwise healthy and they have a strong grip too, that's two things in favor showing that they are going to have a better likelihood to not suffer adverse events from some chronic diseases. Now, if they're also generally healthy and they have the weak grip, then it's like, all right, well, why? Is there another underlying condition? Are they currently in pain? Do they have a tendinosis that we don't know about? So again, it's a corollary, not a causative, but it's one that we can also screen for and just make that assessment at the time. So we can do endurance tests. There are parameters to follow. There are age-based, sex-based parameters for how long you should be able to hold yourself in a horizontal plank position utilizing your low back muscles. And it is a corollary that it's cheap and it can kind of give you an idea of your general low back status and how severe you would likely have a low back pain episode if you're going to develop low back pain. So use it. but also understand where it's coming from and what it means. Efficacy and safety of pregabalin in the management of low back pain, a comprehensive meta-analysis. I bring this up here just to kind of reiterate that while we are a chiropractic office, while we are conservative and believe it should be the first thing that everybody does and tries in the management of low back pain, we also are living in reality where it isn't always the case for everybody to be able to manage their conditions purely conservatively. And so I want to use this study just to take that time to say it. And so for me, pharmacology isn't an emphasis of the practice. I'm not going to go through all of these different parameters that they did. It is not my place to speak about it. I just want to show you the results and conclusion. 18 total studies were included. Pregabalin demonstrated significant pain reduction at 4, 6, and 8 weeks compared to control groups. It also showed a significant greater improvement in anxiety and depression scores, quality of life, and sleep quality. There were no significant differences regarding disability and adverse events in the study groups of pregabalin. Pregabalin is potentially a useful treatment in neuropathic low back pain. So that is a subcategory of back pain. We have to understand that it is very complex with different mechanisms and different potential avenues that are generating the pain response in the area. Neuropathic, or from the nerves, is one. So pregabalin demonstrated significant improvements in pain relief, associated symptoms of anxiety and depression, and enhancements in quality of life and sleep quality. In addition, it exhibits a favorable safety profile. So I'm going to leave this with the last sentence of the conclusion. Nevertheless, the findings should be interpreted with caution due to limited quality of evidence and the inadequate reporting of pain etiology in several included studies. So I'm not going to say too much of this one other than what I've currently said. It is out there. I always believe in the right treatment for the right person at the right time. And in today's age, with today's advancements, that also has to have a conversation of collaborating with medical providers that utilize pharmacology in the management of some particularly pervasive, painful conditions. So just food for thought as we continue on with the last 3 studies. Association between spinal manipulative therapy for low back pain with or without sciatica and opioid use disorder, a retrospective cohort study. This is just saying what a ton of other studies have said, that utilization of services like you see at a chiropractic office with spinal manipulative therapy will reduce opioid utilization. So 25,000 patients remained per cohort following matching. Comparing the spinal manipulative therapy cohort to the ibuprofen cohort, there is a significantly lower incidence and risk of opioid usage, long-term opioid use, and opioid prescription. Okay. Spinal manipulative therapy patients also received fewer opioid prescriptions overall. It's said what we've known for probably 15 to 20 years, but it's always nice to see additional research backing up and adding layers of confidence to being able to make statements like that. Does the addition of manual therapy to exercise therapy improve pain and disability outcomes in chronic low back pain? A systematic review? Short answer, yes, but we have to understand what manual therapy is used for in this context. So briefly, is there anything really worth talking about in the methods? Let's go to, pardon me one sec. They were comparing manual therapy plus exercise with exercise alone, something we've seen in dozens of other studies as far as a setup. Participants consisted of adults and older adults suffering from chronic back pain for over 3 months, recruited by researchers following examination by a health professional. Exercises consisted of strengthening, stretching, and stabilization exercises. Manual therapies included spinal manipulation, massage, soft tissue mobilization, myofascial release, and muscle energy technique. The main outcome scores were pain and disability, with secondary measurements including quality of life, flexibility, strength, spinal mobility, and general satisfaction. Results is what we've seen in every other study doing this exact setup. 10 studies met the inclusion criteria, with 8 reporting pain and or disability improvements with the addition of manual therapy, and only 2 reported no benefit. The conclusion says what I basically can say in much shorter terms. The review found that manual therapy as an adjunct, keyword, to exercises provided increased improvements in short term, another keyword, pain, function, and disability outcomes than exercise alone in the management of low back pain. The addition of manual therapy is recommended for at least short-term pain and disability relief in low back pain patients. That's it right there, folks. The keywords being short term, the keywords being adjunct. This isn't something where, exercise is always going to be the long term big play. But if it's one of those things, like I've seen patients, they're just, air quotes, dying in the short term. They have too much pain to want to do the exercises. They have too much fear, kinesiophobia, etc. Then by all means, we're going to utilize manual therapy to the best of our ability in order to get them over that hump so they can get back to doing the exercises that are going to get them longer term results. Really, it comes down to we shouldn't demonize manual therapy. We just have to understand its role, how to use it, and when to use it. So I've seen some people out there where, manual therapy is terrible. It's the worst thing in the world. It's not going to get you what you want. And I think it really comes down to just understanding how it's being quote unquote sold. If it's being sold as it is the only thing you need to take care of your condition, then yes, I would agree. It's not a great sale. It's not a great thing. It's not a great narrative. It's not a great discussion, and you should find a different provider. If the person who is a manual therapist and a manual therapist only is saying this is a great adjunctive thing that you can do in addition to other longer term beneficial interventions, then that person knows exactly what it is, and they will be just fine to include in your healthcare team. So just understand what it is and why we use it. It is a great thing to use in addition to, especially in these short-term flare-ups and episodes, but not something that we should stand alone and say it can do everything for us. Lastly, chronic low back pain, causal risk factors identified by a big randomization with a cross-sectional cohort analysis. So this has a lot of words, a lot of results, but basically, if we go to the purpose and then the conclusion, that will probably be the best for this discussion. The objectives of the study were to using rigorous confounding control, compare associations between modifiable causal risk factors identified by Mendelian randomization studies with associations in chronic low back pain populations and estimate the association of those risk factors with chronic low back pain outcomes. Basically, what risk factors can we pull out for people that have low back pain that they can then tackle to reduce the likelihood, severity, incidence rate, etc. of low back pain? So big patient sample size, methods, they highlighted 5 risk factors with sub-risk factors broken out from there. And if we go to the conclusion, several modifiable causal risk factors for chronic low back pain, like alcohol use, sleep disturbance, depression, and obesity, are associated with PEG. Well, what's PEG? P-E-G. Something that I forgot to mention at the beginning, so let's highlight that now. I just got to find it up here. It's either in the methods or the background context. It is not in the background context, so let's go to methods. It's essentially physical activity or general physical activity, pain, and what's the E? This is great. I'm leaving it in here because you get to see how things really are in this office. No unedited, only make me look good things. Oh, I know I had it here somewhere. Oh, outcome measures. Wow. I am terrible. So PEG is pain, enjoyment of life, and general activity. Sorry about that, folks. So going back to talking here for the risk factors, alcohol use, sleep disturbance, depression, and obesity are associated with pain, enjoyment of life, and general activity. Okay. After adjusting for those variables in the methods, oh, sorry, I said that. I said, man, last study, and I'm just really saying this incorrectly here. Several modifiable causal risk factors for chronic low back pain, alcohol use, sleep disturbance, depression, and obesity are associated with pain, enjoyment of life, and general physical activity after you adjusted for confounding variables identified above. Convergence of our findings for sleep disturbance, depression, and obesity with these results strengthens the evidence for a causal relationship, not just correlative, between those risk factors and chronic low back pain. The estimated effect of risk of a risk factor, and the change for the pain, enjoyment of life, and general physical activity were the largest for, so essentially largest risk factors, sleep disturbances and obesity. So again, those are generally modifiable. Those are things that you can take control of. These were the largest standout risk factors, modifiable risk factors for chronic low back pain. Future analyses will evaluate these relationships with additional longitudinal data. So as of right now, lots of modifiable risk factors are now being shown to be not just correlative, causative now, and they seem to show that the sleep disturbance and obesity take the biggest toll on chronic low back pain. So if you have chronic sleep disturbances and or if you know you're in the obesity category, these are things that are modifiable that we can do to reduce your risk, severity, etc. for chronic low back pain. But clearly, I'm getting a little bit tired, so I'm going to call this Thursday research review for now. And until next week, thank you.